Hello, everybody, and welcome to today's Family Medicine Grand Round for June 22nd. For those of you who are interested in claiming CME credit, the code is listed for you there. I will be going over some additional information here in just a moment, but just please remember to make sure that you do request that CME before midnight tonight. So as we go to the next slide here, I will briefly go over the process. The next slide. So here it just shows the couple of steps that you need. If you have not yet registered, please send your email address to the toll-free number listed. Once you've done that, for each of these sessions, you just need to text attend, and then the code for today, which is listed there, you'll text attend plus the code to the toll-free number, and it should send you back a message that you have successfully registered your attendance. But if you're having any issues, I'll put my email in the chat box here. After we get started, please feel free to reach out to me. Next slide. So we're going to go ahead and get started here. If you would, please just make sure that your microphone is muted unless you're commenting or engaged with conversation. Also make sure that you are attentive to the presenter and engaged in the session. And then towards the end here, I will be putting in the link for feedback that we want to give our presenters. So please help us out with that as well. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and our educational partner is the South Central AHEC, and our mission statement is listed there for you. Next slide. Going back to CME, if you do claim CME credit, you may want to check your transcript from time to time. You can do that at the CME office website listed there. But if you have any questions, please feel free to reach out to them, or you can reach out to myself as well. Next slide. For those of you who are AAFP members, we also do offer credit for this presentation through the AAFP as well. So please be sure to register if you are a member. And if you have any questions, their information is there. But again, you can always reach out to me. Next slide. Also, as we get started, we just want to make sure that we do mention that it is our goal to address these nationally established physician core competencies that you see listed here. Next slide. And we do also need to mention that Dr. Bell has no financial relationships with ineligible companies to disclose. Next slide. So today we have Dr. Keisha Bell here with us. She's going to be discussing racial disparities in clinical communication. So I will let her get started with her presentation.
Hello, everyone. Thank you for having me. I am excited to talk about this topic and share what's kind of going on in the literature related in this area. I am an assistant professor in the departments of psychiatry and OBGYN at the University of Rochester Medical Center. In my roles there, I wear a lot of different hats, but the three main hats are I do communication coaching with physicians. So I work with physicians regarding their patient care and give them direct feedback about how they're communicating with their patients. That involves some observation of their clinic. And I do that also with the residency or OB residency. The second kind of major hat that I wear is that I am a co-officer of diversity and inclusion in the Department of OBGYN. And so I'm involved in several different initiatives related to those areas. And then lastly, I have a small faculty practice in an OBGYN setting where I see patients along the reproductive spectrum. So the objectives for today, by the end of our presentation, my hope is that you'll be able to summarize racial disparities in maternal health outcomes, describe 3 ways in which clinicians differ in their communication with Black patients as compared to white patients, and to employ at least one practical step toward improving communication with Black patients. So the year was 1988. Can you tell by the ruffles and the lace? I am about 4 years old in this picture. It was Easter Sunday. I'm in the center with the sugar rush from all that Easter egg candy, saying something probably incoherent and only funny to me. My brother in the gray suit behind me with the downward gaze is likely reminiscing on the good old days when he was the only child and center of attention. My mother is to the left of us with a sly, incriminating grin. Perhaps she's the one that gave me all that candy. Perhaps she's hoping I'll go down for a good nap when we get into the car. Onlookers comment, "Oh, how precious," as they try to interpret my sucrose-induced babblings. 4 years later, my mother died of cancer. The year was 1992. It was May when she learned of her lung cancer, and before the start of my fourth grade year, she passed away. It was a late stage diagnosis. She was a smoker and an underinsured woman working in a school cafeteria, an extrovert who never met a stranger except at the doctor's office, which she rarely visited. I'm comforted by the stories of her somehow being able to make meaningful connections with the staff, with the medical team during her cancer treatment. Turns out she, in fact, never met a stranger. I was then reared by my grandmother, who died of cancer 6 years after my mother. The year was 1998. After winning a battle with breast cancer several years earlier, she lost the fight with ovarian cancer. Nonetheless, my grandmother was a survivor, a woman with a fourth grade education whose mother died when she was 4. My grandmother survived the Jim Crow South, KKK domestic terrorism, and desegregation, yet she only went to the doctor when all else failed. I vividly remember her taking a spoonful of mustard once when her blood pressures were too high. And I just did a Google search, and there maybe is some truth to that there are some blood pressure benefits in mustard. So how did Granny have that wisdom? How did she know that? Clearly, women's health, illness, and death were an early part of my life, and I naturally took interest in health and well-being. I questioned things like, why don't people go to the doctor more? Why don't people change their behavior? Which led to more evolved sociocultural questions like, why do all the Black people live on that side of town? Why are all Black people sicker than everyone else? It only made sense that I'd eventually pursue a degree in clinical psychology with an emphasis in health psychology, as I have a strong affinity towards women's health issues. You may be wondering at this point, why in the world would a photo album contain both personal photos and stark diagnostic imaging? Don't they belong in separate albums? What I've learned thus far is that this is a common conflict in medicine, holding both the humanity and biomedical, the challenges of seeing them both together, that patients have lives and dreams and aspirations in the context of illness and functional limitations. A graduate professor once gave me the feedback that, Keisha, you tend to take two ideas that seem completely unrelated and find the commonality in them. I don't think that was positive feedback at the time. However, it was accurate in highlighting my natural affinity, which is to help others see those connections that often go unnoticed and to see patients as living narratives, and to ask those questions that push the quality of care forward. So we'll spend a little bit of our time talking about the maternal health landscape as it is today, and review some of the contemporary inspirations for the work that I do. The year is 2022, and racial and ethnic disparities in obstetric outcomes are well documented. Black women are twice as likely to suffer a maternal morbidity and 3 to 4 times more likely to die from a pregnancy-related cause than white women. Black maternal deaths are largely due to cardiovascular and coronary conditions, including cardiomyopathy, preeclampsia, eclampsia. Hemorrhage and embolism are also listed among the top maternal health complications for Black women. And while nearly half of maternal deaths are considered preventable, there's evidence to suggest that Black women are more likely to experience a preventable maternal death than their white counterparts. When it comes to birth outcomes, Black women don't fare any better either. Black women experience higher rates of preterm deliveries and infant mortality. In fact, infant mortality rates are highest for Black women in the US, with Black infant mortality rates remaining double that of white babies for the past 35 years. Commonly cited reasons for maternal disparities include chronic illness, pregnancy complications, advanced maternal age, lack of prenatal care, lower levels of educational attainment, and low SES. While each of these factors do contribute to the increase in maternal mortality overall, the disparity between maternal mortality between Black and white mothers cannot be fully explained by those factors alone. Instead, what we see is that racial disparities in mortality and morbidity persist even when controlling for factors like SES, education, geographical location, pre-pregnancy obesity, risky behavior, and poverty. In fact, Black women with at least a college degree had greater rates of infant mortality and life-threatening pregnancy complications compared to white women who had not graduated from high school. Because of this, factors such as hospital quality, institutional racism, provider biases have gained increased attention as contributors to disparities. Numerous studies demonstrate that patients of color receive fewer recommended treatments for diseases ranging from cancer to HIV to heart disease to neurologic disorders compared to white patients, even after controlling for insurance status, access to regular primary care physician, and other factors. More recent data suggests that Black women receive obstetrical care that is suboptimal as well. Black serving hospitals tend to perform worse on the vast majority of birth outcomes like elective deliveries, non-elective C-sections, even after adjusting for socio-demographic characteristics, clinical factors, hospital characteristics, and the like. While standards of care and best practices for addressing obstetric emergencies do exist, they vary in execution, which means that some women receive appropriate high-quality care while others do not. Lastly, and certainly not least, postpartum depression is one of the most common complications of childbirth for women, affecting 1 out of 7 women in the US. Prevalence rates for postpartum mood disorders are not well studied in Black women, and findings appear mixed, with some studies showing greater prevalence, while other studies suggest similar rates among racial groups. And so more work is needed in this area, especially because we do have adequate data to suggest that Black women are less likely to receive mental health treatment, and when they do, they're less likely to follow up. Postpartum depression has been linked to poor maternal bonding, premature birth, and behavioral and developmental delays, which may perpetuate disparities given adverse outcomes can be avoided. So efforts to understand maternal health disparities at the individual level have not sufficiently explained poor outcomes for Black women. And given that approximately 40% of maternal deaths are preventable, factors such as racism and provider biases have gained increased attention as of late. Scholars contend that there is a legacy of poor treatment of Black patients by the medical system, including experimentation and exploitation of Black people that goes back as far as slavery. Pictured here is John Marion Sims, who's considered the father of modern gynecology and who was a former president of the American Medical Association. He performed reproductive experimental surgeries on unanesthetized slave women to perfect his surgical technique. Francois Marie Prevost, a slaveholding surgeon, also performed experimental C-section surgeries on enslaved women. And these two physicians are only a handful of physicians who practice acts of injustice towards Black women. Additionally, during this time, the transatlantic slave traders hired surgeons for the Middle Passage to preserve the cargo. In the slave markets, physicians inspected the bodies of enslaved people to certify their soundness. And the ability to accurately determine the market value of Black bodies was considered an important competency for Southern physicians. Even after death, Black bodies were used as teaching material in white medical schools and in medical museums. We see a perpetuation of non-consensual acts post-slavery as well, such as the use of cell cultures without consent in the case of Henrietta Lacks or forced sterilization. These and many other inhumane acts were justified by scientific research that proposed Blacks were biologically different than whites and thus inferior, and also that suggested that Blacks have an increased pain tolerance. Since the time of slavery, Blacks have viewed Western medicine with punishment, or associated Western medicine with punishment, loss of bodily control, and degrading public displays. Fast forward to today, and new Black moms often find their self-reports of painful symptoms overlooked or minimized by their clinician. Some studies show that healthcare providers still hold ideas that Black people have less sensitive nerve endings, thicker skin, stronger bones, which may cause providers to underrate Black patients' pain, resulting in less appropriate treatment recommendations. Pictured above is Kira Johnson. She spoke 5 languages, held a pilot's license, enjoyed racing cars, skydiving, traveling. She was a wife and mother of 2 sons, one pictured here. She didn't have any major health concerns, and she attended her prenatal visits. When Kira became pregnant with her second child in 2016, she underwent a cesarean surgery. Her health began to decline shortly after. Her husband noticed blood in her catheter and alerted the team, but the family went over several hours without her symptoms being addressed. When she eventually made it to the OR, she had an accumulation of 3 liters of blood in her abdomen and died shortly after of complications related to postpartum hemorrhage. The Kira Johnson Act was introduced to the House of Representatives in February 2021 and is awaiting passage. The bill would provide funding to end preventable maternal mortality and severe maternal morbidity, and hopefully close disparities in maternal health outcomes. Shalon Irving was an epidemiologist for the CDC. She was in her mid-30s when she conceived. She had a history of high blood pressure. She delivered via C-section. After discharging home, she had several appointments with her PCP for hematoma, blood pressure spikes, leg swelling, rapid weight gain, blurred vision. However, she was told that she was displaying symptoms of, she was told to kind of wait it out because her symptoms were normal. Unfortunately, she died, I think, a few days after her last PCP visit, displaying symptoms of complications for high blood pressure. These stories and others like it challenge the mother blaming narrative, which has its roots in slavery. For example, when infants born to enslaved women died, slave owners sought the advice of white physicians, who in turn blamed mothers and plantation midwives for the infant's death, which was more likely the result of poor nutrition and harsh labor than the fault of the midwife or the enslaved mom. Many health equity scholars caution us as clinicians and researchers against perpetuating mother blaming, as doing so ignores the broader contextual, environmental, and social factors that impact the health of the mother. Moreover, individual factors alone may result in stigmatization, scapegoating, heightened surveillance, and criminalization. Instead, stories like Kira's and Shalon's should prompt us to ask what other factors are at play here. Is there something about the way in which pregnant and postpartum women interact with the healthcare system that may help us better understand maternal health outcomes? So the Landmark Institute of Medicine's 2003 Unequal Treatment report emphasized that there's a potential influence of patient-clinician communication on both mitigating and perpetuating health disparities among racial and ethnic groups. Factors that may contribute to health disparity in the clinical relationship include power imbalance, clinician unintended bias, and communication skills. Implicit bias refers to negative attitudes towards and beliefs about a group and its members that are spontaneously and automatically activated. Studies show that healthcare providers hold conscious and unconscious negative stereotypes of Black patients as being less educated and adherent than their white patients, and that these biases may contribute to disparities. So I want to take a moment here and have you interact via coming off of mute or by entering some responses in the chat. What are some of the ways in which you think bias impacts the care of Black women?
I think sometimes it's just nonchalance or like maybe not going the extra mile you would have for another patient.
Mm-hmm. Absolutely.
And I think everything you just said of not being taken seriously, that, oh, there's a higher pain tolerance, they'll be fine.
Mm-hmm. Yep. I think that they're right. There isn't always this intentional, like I'm trying to intentionally harm you. These are just some of the things that we have ingested throughout the course of our lives about different racial groups. And so kind of a knee-jerk response when we're meeting with patients who are different from us in whatever way that they're different. So I think, yep, great. Physicians can interpret attitude and respond negatively. And it can impact how we conceptualize presenting concerns and our treatment recommendations. Absolutely. Great comments. Thank you, everyone. So researchers actually asked some obstetric clinicians for their perceptions of how racism affects Black women's pregnancy experiences. One midwife described the potential for differential treatment regarding breastfeeding counseling and shared that providers may make assumptions, someone just said this, based on race and assume she's probably not going to breastfeed anyway. So I'm not going to, put a lot of energy or effort into counseling her. An OBGYN participant shared how these assumptions can lead to differential treatment for Black mothers. She recalled being on L&D and observed a urine tox screen done on the Black baby, although not indicated based on the protocol, and a tox screen being omitted for the white baby when it was indicated per protocol. And so the hypothesis is that if a physician believes that a Black patient would not be compliant or cooperative, this may affect their treatment recommendations and plans. 2 lines of research have explored the influence of providers' implicit bias on healthcare received by Black patients. The first line of research uses hypothetical vignettes to examine the impact of implicit bias on treatment decisions. This research has not found a consistent pattern of association between implicit bias and treatment decisions. So some studies using clinical vignettes have found a significant correlation between high levels of pro-white bias and treatment responses that favored white patients, and others haven't. And so health disparities researchers argue that using clinical vignettes, which may not translate to real world decision-making, may not be the best avenue to pursue. And they also may be subject to social desirability responding. And so researchers also assert that without really observing a provider in their real world work environment, it's hard to know how their implicit biases translate into differential care. And also that without such high quality evidence, it will just result in ignoring our biases, which would potentially increase health disparities. The second line of research focuses on the influence of providers' racial bias on their communication and the patient's reactions in actual healthcare interactions. And so these studies have found that primary care physicians, their bias negatively affects their communication and or their Black patients' reactions to them. For example, one study assessed physicians' ability to quantify pain in Hispanic patients compared to non-Hispanic patients presenting to the ED. The researchers found that the physicians could accurately judge patients' pain severity regardless of ethnicity, yet still provided less pain medication to Hispanic patients with severe injuries, despite controlling for multiple factors like language, insurance, severity of injury, physician characteristics. Similar findings were seen in a follow-up study with Black patients who received less pain medication despite similar reports of pain as white patients. Another study revealed that white physicians are more likely to miss depression symptoms among minority patients and often do not recognize patients as being depressed even when the patient shares emotional concerns. These patients are also less likely than white patients to be referred to mental health specialists by their primary care physicians. These findings beg the question of whether pain is just unrecognized and thus untreated, or recognized but not treated due to stereotypes about patients of color. There's also evidence that Black patients who perceive discrimination in the visit report lower information giving by their provider in that visit, lower medication adherence, and are also more likely to delay completing medical tests and treatments, and also are more likely to underutilize healthcare services. One study found that higher implicit bias in oncologists was associated with more patient difficulty remembering the contents of the interaction, which ultimately impacts the patient's ability to follow through with recommendations if the plan is just not well remembered. I apologize, there's a lot on the screen. But I thought that these quotes from a few qualitative studies were all worth sharing. So Black perinatal women were asked to identify desired characteristics that they'd like in their communications with their providers. Major themes arose around a desire to have their providers know and remember them. They wanted their providers to understand the context of their lives separate from their prenatal interactions. They wanted to be treated with respect and have compassionate care. While this doesn't sound like a big ask, qualitative data suggests basic skills are lacking in perinatal visits with Black women. Black women experience their visits as robotic, impersonal, report being spoken to in a condescending and or accusatory tone, not getting enough information from their provider, not having informed consent around all of the events that take place in the medical visit or interaction, and not being allowed to participate fully. So something is happening here in the real world environment that we just don't quite have a pulse on as it relates to bias. And clearly there is more work to be done in this area to understand the pathways between bias and treatment adherence for Black patients. So let's take a pause and self-reflect. These are questions for your own self-reflection, and you do not need to enter a response in the chat or say them out loud. But I do encourage you to answer at least one question within yourself, and I'll just give you a few moments to do so. So asking such questions and acting on your, reflecting on your thoughts is a vital process in providing exceptional care to patients. And so I encourage you to continue to dwell on some of these questions if you want to take a screenshot or, jot a few of them down. I think it's important to be thinking about how your communication or your experiences with patients vary across race and ethnicity. So let's move on to the second part of our objective, which is to talk about communication disparities. So similar to health disparities, communication disparities are well documented. Findings from a 2018 systematic review suggest that Black patients tend to have both poor observed communication and self-reported perceptions of patient-physician communication when their physician is non-Black. Data suggests Black patients regularly experience less information sharing, less active participation in decision-making in the visit, and report lower satisfaction with care and lower levels of trust in their physician. There's strong evidence in the social psychology literature that implicit racial bias can influence nonverbal behavior, so body posture, eye contact, and paraverbal behaviors, such as the amount and speed and pitch of speech during interracial interactions. In general, research shows that when interacting with Black patients, physicians have more of a biomedical focus in the conversation, provide less information, spend less time building rapport, and are more verbally dominant in the visit, and their visits tend to be shorter. White providers who score higher on measures of implicit bias have been shown to speak faster, dominate conversations, have shorter visits, display less warmth, display fewer positive nonverbal cues, so there's less affect, and use more first person plural pronouns, which may maintain power and control. So an example, so we're gonna start exercising, right? It's thought that when negative stereotypes and implicit biases are activated, it may be challenging for providers to engage in emotional rapport, such as things like displaying empathy, respect, validation, and concern for Black patients. Research in obstetrics is limited, but there is data to suggest that Black women are more likely than white women to experience poor communication during their perinatal health visits. For example, one study examining mistreatment during pregnancy and childbirth found that Black women were more likely to have experienced mistreatment by a provider compared to white patients, such as being shouted at, being ignored when they requested help, having their privacy violated, feeling that there was coercion in treatment, so being coerced into a C-section delivery, and also experiencing that their pain symptoms were dismissed. Preliminary qualitative data suggests Black women who report feeling mistreated were disinclined to attend subsequent prenatal visits, which makes sense, when there was perceived lack of trust, clear communication, closeness, and continuity. Pregnancy involves engagement with the health system, frequency of engagement with the health system due to the nature of the condition, and implications of poor quality communication is especially relevant to Black women who are at an increased risk of adverse maternal health outcomes. Studies indicate that clinicians tend to overestimate their communication skills, even when patients view the communication exchange as inadequate, making communication an area for targeted intervention. Agiwara and his colleagues developed a conceptual model to explain the ways in which communication may mediate the association between bias and health outcomes. The researchers proposed that provider implicit bias may manifest as communication behaviors during the medical encounter. This notion is based on previous work that has shown associations between provider communication and variables such as patient satisfaction, trust, and health behaviors. Qualitative studies demonstrate a relationship between trust and willingness to follow recommendations for Black pregnant patients. Thus, health disparities researchers theorize that substandard communication with Black patients may then contribute to health inequities for Black patients through low trust, satisfaction, treatment adherence, and attendance. For example, a subtle bias assumption that a patient will be non-adherent may lead to verbal and nonverbal behaviors in the visit, such as less partnership, talking over the patient, facing the computer, that then lead to poor satisfaction and trust, which may then impact patient health behavior. The blue arrows here highlight that communication is a constant feedback loop, and both patients and providers are simultaneously adjusting to the information being received. This characterizes the notion of reciprocity norm, which means we tend to respond to others favorably or unfavorably when when others treat us positively or negatively. This would mean that positive provider communication behaviors are likely to induce positive patient communication behaviors, while negative provider communication behaviors are likely to induce negative patient communication behaviors. For example, approaching patients with a condescending tone may decrease the likelihood that patients will feel heard and valued. For example, feeling that the provider is being insensitive to their needs. And then the patient communicates less with the provider and asks fewer questions, which the physician then interprets as passivity or low intelligence, which then exacerbates disparity. This negative interaction may affirm providers' negative beliefs about Black patients. However, the converse may be true as well, that positive affect of the provider may encourage patient engagement, which in turn may enhance adherence. There's good evidence to suggest that repeated positive contacts with out-group members is associated with reduced stereotyping, prejudice, and so repeated positive interactions with Black patients, as the white arrows suggest, may reduce provider implicit bias over time. Thus, the encounter can be a corrective experience for both parties involved. A commonly overlooked area when it comes to communication disparities is biased language in the written communication, so the medical record, which can influence the quality of care that patients receive. A 2018 vignette study examined how language in the medical record of a hypothetical patient with sickle cell disease would influence physicians who read the note. Readers of stigmatizing language had more negative attitudes toward the patient and opted to administer less pain medication, even though all clinically relevant information was the same. And this potentially means that what is written in the medical record can transmit bias and affect the quality of care that patients receive. A recent meta-analysis of actual patient records revealed Black patients were 2.5 times more likely to have at least one negative descriptor in their history and physical notes compared to white patients, even after adjusting for sociodemographic and health characteristics. These findings raise concern about the possible transmission of stigma in the medical record, which may exacerbate racial and ethnic healthcare disparities. Researchers suggest avoiding the use of terms like difficult, challenging, resistant in describing patients due to the negative connotation. And in our own department, we are making efforts to avoid using the term refused and replacing that with declined. I want to briefly touch on racial concordance. Racially concordant visits have been linked to longer visits with more positive patient affect, partnership building, higher levels of patient trust, greater satisfaction, and greater ratings of the visit overall as being more participatory in terms of patients being able to participate and engage in shared decision-making. But I want to caution you that this doesn't mean the solution is for Black patients to see Black providers and white patients to see white providers. Approximately 80% of Black patients see non-Black physicians when they seek medical help. And given the shortage of Black providers, this doesn't really address the problem of disparity. Secondly, it doesn't facilitate accountability of all physicians to treat patients equitably or for the larger healthcare system to work to address disparities. Moreover, some researchers have speculated that it is not racial concordance, but the clinician's interpersonal and patient-centered communication that affects satisfaction and trust. It's possible that racially concordant clinicians may increase a patient's trust and positive feelings about how their health care visit will go, but clinicians who are well-trained in communication and cultural sensitivity can also cultivate patient trust. So why the focus on communication? The provider interaction is integral to health outcomes as it's the main gateway through which patients engage the healthcare system. It also represents an opportunity to address documented disparities in communication and perhaps be one part of the solution to addressing maternal health outcomes. Also, a learnable skill. One of the critiques of implicit bias training is that it often focuses on increased awareness of someone's bias without giving them specific communication strategies. Given that clinicians overestimate their communication skills and may be unaware of blind spots impacting care, it's argued that improving provider communication behaviors might be a more practical and attainable approach to improving care outcomes than implicit bias training alone. For example, one study demonstrated that patients with whom physicians communicated poorly exhibited a 19% higher risk of non-adherence when physicians were trained to communicate more effectively. When physicians were trained to communicate more effectively, adherence improved by 19%. Sorry about that. And other researchers have encouraged clinicians and researchers to develop culturally respectful communication skills that are based on specific communication behaviors. So observing communication behaviors and coming up with training programs that actually address those behaviors and reduce disparities in healthcare. So let's move on to some strategies to enhance communication. Maybe you can relate to this physician who is quoted is acknowledging a need to rebuild trust with marginalized communities, but doesn't really know how to go about doing that. She says, "We have to be proactive, and I'm not exactly sure how to do that. Oftentimes, conversations about health disparities can leave you feeling deflated, defeated, as steps forward seem unclear or perhaps nearly impossible. I wish that this was the section of the talk where I give you some foolproof strategies that would eradicate inequity and any form of bias in the medical encounter. And I'm sure you wish that that was this section as well. But more work is needed in the area of communication and health disparities, especially as it relates to observational coding of communication behaviors and racially discordant visits. So we don't really know the pathway exactly of how communication influences treatment adherence or patient outcomes, but we do know two things: that patients have told us what is going awry in their medical visits, and we do know that there are evidence-based communication approaches that are going underutilized in medical visits. So in the next few slides, I will share some frameworks and evidence-based communication behaviors that have a positive effect on communication quality. However, I want to caution you against using these prescriptively, as doing so can perpetuate disparity. So I am purposefully reviewing the frameworks first and then the behaviors second. The goal is to be practical, but not prescriptive. So before focusing on what to do in the room, it's beneficial to first do a little bit of a self-check-in. Many of you have probably heard the term anti-racist. It's the opposite of being, the opposite of racist is not racist, it's anti-racist. An anti-racist is someone who expresses the ideal that racial groups are equal and supports an anti-racist policy through their actions or expressing anti-racist ideas. This is a person who believes problems are rooted in power and policies rather than in groups of people. I know this sounds complicated and vague, and so I'll give a few examples. Anti-racism is really just about taking action in some way. So for example, a department hosting a brown bag series on Black maternal health disparities and bias to increase awareness is a form of anti-racism. Creating a patient advisory board to bring Black voices to the table to improve quality of care is a form of anti-racism. OB residents noticing that patients have food needs and starting a food pantry in the clinic that they work in, where all clinicians contribute, is a form of anti-racism. Inviting a colleague to use more inclusive language when they're using an outdated term, or medical students advocating to change a policy for incarcerated birthing patients to no longer be shackled while they're delivering, are examples of anti-racism. And these are just a few examples of anti-racist acts that have taken place at our own institution. And so as you approach identifying and monitoring your biases, ask yourself what growth zone you are in and identify one goal in that zone to work on improving. So if you find yourself, and you may want to take a screenshot of this, if you find yourself in the fear zone, maybe you're only talking to people that look like you. So maybe the goal or challenge is to talk to more people that look different than you do. Or if you're in the learning zone and you're aware of some biases and feel subconscious about them, maybe you need to scale back and identify one bias and develop a mechanism for disrupting it. Or if you're in the growth zone and you speak out when you see racism happening, maybe you need to refine how you're doing that so it comes across as, less harsh or severe. Or maybe you want to mentor others who are still growing in this area. A few other guiding principles include cultural humility and trauma-informed care. Cultural humility has gotten a lot of attention lately as we've come to realize we will never be competent about another person's culture, race, ethnicity, or experience. Cultural humility acknowledges that patients are embedded within a cultural context and that this context may contribute to their health outcomes. It's our role to appreciate this and respect it. There is an emphasis within this model on mutual learning and equalizing power imbalance in the physician-patient dynamic. It is respecting that there are at least two experts in the room, which reduces paternalism and increases patient engagement. The second approach is a trauma-informed care approach. Trauma-informed care is strengths-based. It is caring for patients mindfully and with compassion. It seeks to avoid unintentionally triggering trauma or a stress response and is aimed at increasing patient empowerment, choice, collaboration, trustworthiness, and safety. Trustworthiness in their physician, rather. The major tenet of trauma-informed care is acknowledging that many people have experienced a traumatic event, and traumatic events also include experiences of racism. There's data to suggest that Black teens average more than 5 racial discrimination experiences per day, ranging from coming across a racist image, hearing a joke about Black people, observing a store clerk giving preferential treatment to a white customer, getting looked at suspiciously, being teased because of their skin tone. And so this then moves us away from asking, why can't you just get it together, to what is happening outside of this room that's contributing to your health. It moves us from accusation to collaboration. So Presence 5 is a humanism focused framework, meaning its focus is to foster meaningful connections between patients and providers by attending to the human aspects of medicine. This framework was originally developed to help clinicians remain connected while balancing administrative demands of clinical practice and also to reduce medical errors. This frame outlines 5 evidence-based practices to enhance clinical communication. Recently, researchers have adapted this model to embody a racial justice framework that is designed to promote clinician self-reflection of biases, address racism and known gaps in care for Black patients, and in doing so, hopefully promote health equity in their clinical care. So we've come now to talking about some very specific behaviors. And so we'll go through each of these and give some examples and recommendations. So we know that Black perinatal patients want to feel known and seen. And this is especially relevant in settings where discontinuity prevails. So the intended behavior here is to prepare with intention. Means familiarizing yourself with the person you're about to meet while being open to values and perspectives that they might bring to the visit. Here, you want to consider how your identity and biases could influence the encounter and being mindful of prejudging patients based on what you've reviewed in their chart notes. So a few examples of questions to ask yourself as you're reviewing notes or collaborating with colleagues about a patient You can check in with yourself by asking or noticing, I'm noticing that I'm feeling blank by what I'm hearing or reading. And then getting curious by asking yourself, why is that? You can also notice your immediate response to the patient by saying or thinking, my immediate reaction to this patient is blank. Again, getting curious about why is that? And then actively working to reframe the encounter. I acknowledge that, maybe you feel the weight of your professional responsibilities, so time constraints, productivity demands, a learning curve if you're a trainee, or the patient's, picture is just really diagnostically complex. And reminding yourself that yet there are at least two experts in the room. Also reminding yourself that the patient is not their label or the label that others have shared with you. So maybe you're talking with a colleague who shares some things about the patient that begins to sway your views or beliefs about that patient. And maybe I think of all of these, is the one I would really encourage you to try out even today if you have patience, is to challenge yourself to name one strength by the end of the conversation. Committing yourself to look for strengths rather than getting sucked into kind of knee-jerk categorical reactions to the patient based on their race or ethnicity. The second behavior is related to what we know in the literature about communication disparities. We know that Black patients are more likely to have shorter visits, have providers that speak faster, dominate the speakership. We know that Black patients, pregnant patients, want to participate more fully in their visit. The goal here is to listen intently and completely. So active listening, rephrasing what the patient is saying, listening for their experiences of racism and how this might be impacting their care or their health goals, and reflecting on asking them about their health goals, actually. Another consideration is at the end of the visit, asking the patient if he or she or they felt understood. And if there's anything else that they would like to add to the conversation to feel more understood, is a great way to listen to the patient and have them share the speakership and feel like they have a voice in the visit. So we also know that physicians tend to be more biomedically focused in conversations with Black patients. So that means a physician-led agenda. So it's important to agree on what matters most. Again, remembering that there are two experts in the room. This facilitates partnership building. You'd also want to reframe the interaction as being between two collaborating equals rather than someone high status and then a low status person. Setting an agenda will save time in the visit. It avoids surprise concerns at the end, which extend the visit. Those hand on the doorknob concerns that come up and now the visit is 10 to 15 minutes longer. Patients may withhold concerns until the end of the visit due to embarrassment, stigma, lack of trust in the healthcare system, fear, and you may not have adequate time to address them if this happens. So if you and the patient are both on the same page about what the goals are, you have room then to get to know patients. You have room to do that relational work that Black patients are saying is missing in their visits. Also, check in with yourself for any biases or assumptions that may be affecting how you develop a differential diagnosis. So one way to do this is to ask why behind the recommendation. We've implemented this in our OB residency so that the response is not just because ACOG said so, but actually to understand why ACOG recommend this particular intervention or plan. We also know that physicians spend less time rapport building with Black patients, and that Black pregnant patients want to have positive relationships with their providers characterized by compassion and respect. So connecting with your patient story is one behavior that you can implement in the visit. Doing so by individuation, which is seeing the person as an individual rather than a stereotype. And it means learning more about their personal history and the context that brought them to the visit, to get a sense of who they are. One suggestion that we often give to physicians is to have them ask or say something like, you know, I always like to get to know my patients as people. What personal goals do you have? What plans do you have after this visit? What ways did you take care of yourself this week? And these are examples that not only help you get to know the patient, it also helps you to get to know context that helps direct the plan. And patients feel seen, which is what Black patients often report is missing when you ask them, and you've seen in the literature. Also be mindful of significant others or supports to connect with them as well. So patients pay attention to how we treat loved ones in the visit, whether we ignore them or do we say hello or invite them or their perspectives into the visit. And so connecting with loved ones at present is also equally important. We know that white physicians are more likely to miss depression symptoms among Black patients and are less likely to refer them to mental health counseling. Research shows that empathy is uncommon, surprisingly, in medical visits, and we know that physicians who respond empathically are more likely to have patients with improved satisfaction, adherence, and surgical outcomes. So the goal here is to explore emotional cues, notice and name your patient's emotions, and be open to correction if you get it wrong. Tune in to racial trauma when interacting with patients, be listening for narratives around that patients may bring. Avoid the use of "I'm sorry." This is often misheard as pity and prompts the patient to console you. For example, "That's okay, doc, it's fine." When it's not fine, they've said something that was really, distressing for them, and it's using "I'm sorry" causes them to diminish their own experience. Additionally, empathy can move the visit along. Studies have shown that when opportunities for empathy were repeatedly missed in a visit, the visits tended to be longer and more frustrating for both physicians and patients. So we've covered quite a bit. Based on today's talk, I'd like you to identify at least one area you'd like to work on improving. The goal here is to think about what we've discussed, what areas you feel could be improved, and to commit to working on at least one of them. You might want to ask yourself, the steps that I will take to achieve this are, and if you want to take a screenshot of this and maybe come back to this, maybe you want to chew on it a little bit more, that makes sense. But I do think that after today's talk, identifying at least one communication behavior you'd like to work on would be a good first step. So we'll move on to kind of wrapping up here. In summary, there is a Black maternal health crisis where Black women face disproportionate rates of poor perinatal outcomes, and SES is not a protective factor. There's a long-standing history of devaluing Blacks in our country and a legacy of racism that has created imbalances with some people being advantaged and some people being disadvantaged. Mother blaming has been overutilized and is an unhelpful approach. Researchers are now taking interest in clinician and systems level contributors to maternal health outcomes. Implicit bias may manifest as communication behaviors that impact care quality and adherence through pathways that are not yet well developed. Communication is an essential way in which patients engage in the healthcare system and may be one part of the solution to addressing maternal health outcomes. Clinicians tend to overestimate their communication skills, and so communication is a learnable skill that may be a more practical and attainable approach than implicit bias training alone. I share my references here and photo credits and open it up for any questions we may have or comments in the chat. I'll open the chat. Thank you, Haley. I appreciate your comment. San Antonio is a majority minority city. 70% of population is Latino. Many or most of the ethno-racial disparities are presented today apply to Latino and other ethnic populations in this country. Spanish is spoken in a high percentage of Latino homes. Languages spoken by the patient at home and not spoken by healthcare providers is perhaps the most contributory obstacle in the context of patient-physician communication. Thank you for this comment. Yes, tools we are given are built on history of social injustice, example, hypertension control regimens, CKD staging, which could affect care. We may be frustrated at non-adherence rather than probing into the reasons why they're, yes, absolutely. Bias in the health system training process, which then makes it difficult to find providers who, oh, you all added some great comments. I'm so sorry that I missed some of these as I was presenting. Yeah. Thank you, everyone. Yeah, I think that, we're all on a path here to do better with patients. And I think identifying where we are and the next step to moving that needle forward is definitely important. And so I hope that I provided some practical tips and strategies today that were practical yet not prescriptive, because we don't want to perpetuate disparities by using blanket approaches to patients of color. Thank you, everyone.
Thank you, Dr. Bell. I don't know if anybody else, if we have any other questions or comments from the audience. Well, with that, I just want to thank everybody for joining us. I did put the link in there for feedback for Dr. Bell, and we really do appreciate you coming, well, not coming, but being on video to speak with us today. Thank you so much.
Absolutely. Thank you, everyone. Take care.
Have a great afternoon.